So, a very good afternoon and a very warm welcome to everyone for a much awaited CARDIOQUEST finals. Today we gather not just for the battle of brains, but to celebrate the clinical sharpness, quick thinking, and the spirit of academic excellence in the field of cardiology. It's my great pleasure to introduce our esteemed quiz master of the event, Dr. Karthikeyan sir. Sir has completed his MBBS from Medmemorate Adiparashakti Institute of Medical Sciences, followed by MD in General Medicine from the prestigious Maulana Azad Medical College, New Delhi. Further DM in Cardiology from Dr. RML Hospital, New Delhi. Dr. Karthikeyan is currently a medical faculty at Speed Medical Institute and has made a significant contribution to various medical platforms. He is a former question bank editor at Marrow and also has served a medical tutor at an academy and area plexus. We are truly honored to have him with us, sir. And also, a heartily congratulations and warm welcome to all the finalists. You have already proven your mettle by reaching here. We can't wait to see your brilliance you bring to today's competitions. Let's begin the quiz, and may sharpest brain wins the quiz. Over to you, sir.
Good afternoon, everyone. Thank you, Arnagiri and Dinesh, for asking me to handle this quiz. So, I am Dr. Karthikeyan. I want to conduct this quiz in a manner that you people should be thorough with those basic clinical conditions which we saw commonly in our day-to-day practice. So majority of questions I have tried to take in such a manner that they should help you in your further any PG you take. They should help you as a, basic platform. Okay. So first we'll go to that ECG round. We'll have 4 rounds. First, we'll be having ECG session. So yes, trace the beat. Rules of this round is 2 ECG questions. Okay. Is everyone
Sorry
able to hear me?
yeah, sir, sorry to interrupt you, sir. So,
Okay,
on
okay.
the right side corner,
Okay.
there's a அதை கொஞ்சம் minimize பண்ணா it will be visible
Okay.
to everyone.
Now is it fine?
Yeah, it's fine now, sir. Thank you, sir.
Okay. Yeah. Let's go to the first round. So here we'll be having ECG round. Each team will have 2 ECG questions with 2 subparts in each question, and answer to each subpart you'll have 10 points and total 40 points if all questions are answered right, and time limit will be 2 minutes per question, and passes are allowed at the end. Points for the past question will be 5 plus 5, and if no answer, if then passed, then also you will be having positive marks, no negative points for the any wrong answer. Yes. So can we start? First team is Taki Twins. Are you ready?
Yes, sir.
Yes. Yeah. Before going on to it, can I have a brief introduction about those people in Taki Twins?
Good afternoon, sir. Good afternoon, everyone. I am Supreet Ranjan. I am from ESIC Medical College, Beta, Patna, which is in Bihar.
Okay.
Thank you.
Good evening, everyone. I'm Yashaswini Suman, a third-year student at ESIC MCH, Beta, Patna.
Okay. Come on. Congrats. So first, let's start with the first question. Yeah. The first question is, 25-year-old man complains of chest pain and an ECG was taken, and this is the ECG finding. So what is the probable diagnosis? No negative marks for this question, so you can answer. And also, it is a 25-year-old man with this complaints of chest pain, and this is this ECG. Any guess you want to make, or do you want to go to the next question?
Guess from our side is ST segment elevated MI.
Okay. ST segment elevated MI. Okay. So what wall of heart is infarcted in this question?
We are really not sure about it. We had to just make a guess. Just see if ST segment is elevated and don't know what to say.
We have found ST segment is elevated, but it is elevated in the B3 to B6 as well as
In
1, 2, and B, and also in AVF. Okay, let's. So your answer for this is ST elevation MI. Okay, next question for the same team. A 32-year-old patient, a case of acute pancreatitis, is admitted in surgery ward, and he had multiple episodes of vomiting and loose stools, following which his ECG showed this finding. So in this, two subparts are there. One is what is the cause of this finding, and what is the finding shown in the ECG. Even if you try answering the ECG finding, I can give you marks for the first subpart. This is very common in surgery wards, patients of acute pancreatitis having multiple episodes of vomiting and loose stools, losing some kind of essential ion from the body.
Sir, ventricular tachycardia.
Ventricular tachycardia, okay. So pause. Why is
Sorry,
this
sir.
pancreatitis patient having ventricular tachycardia? Any correlation?
Not that I can explain. Sorry.
Because of? That too after having multiple episodes of vomiting and loose stools.
So potassium loss.
Good. So potassium loss. Any feature is seen here in the ECG of potassium loss?
Sir, usually tall T waves are seen.
Or T waves?
Inversion is seen.
You are nearing the answer. Come on.
T wave inversion.
T wave inversions, and anything specifically seen here? And why is ventricular tachycardia is happening in this patient?
Sir, we don't know.
Okay. So one is cause of the finding. You are told loss of potassium ion, hypokalemia, and finding you are told ventricular tachycardia. Okay. And for this question, what is the diagnosis and how will you manage? So diagnosis you are told FT elevation MI, and how will you manage this patient? Clues there for a 25-year-old. How will you manage? Any guess? These are common ECGs which will be regularly seen in emergencies. Okay. So can we see the? Can we go for passing now? Any team ready to answer this?
So we need
Team 2.
Team 2. Okay.
Sir,
Team 2.
sir, I'm just going on with the guess.
Okay.
Is it Vergada syndrome because of this closed ST segment?
Code ST segment will be
V1,
different.
V2, V3.
Okay, but it will be different. It will be specifically it will be seen in V2, and also there will be ST elevation with a hunchback curving will be there. Brugada syndrome is specifically seen in V1, V2, and V3, mainly in the anterior
Yes.
precordial leads.
Yes,
But
sir.
here you can see elevations everywhere. And team 1 has guessed to be MI. What is the feature which is not favoring in this patient? MI. In a MI ECG, ST elevations will be seen, and also what will also be seen? Okay, pass going to the next team. Anyone wanting to answer?
Sir, maybe the patient is having profound hypokalemia. That is why the patient is having this kind of picture, because we can see in all the leads the ST elevation.
Okay.
Or it may be so possible that the patient has anterolateral MI. Both the walls are involved.
Anterolateral MI also, elevations will be seen in V2 to V6, even in 1 and AVL. But elevations will never be seen in 2, 3 and AVF. There will be reciprocal ST depressions will be seen if it is a anterior MI or a high anterior MI.
Sir, pericarditis is also one of the differential diagnosis.
Excellent, excellent. That is the answer. Who has answered this?
Sir, team Takutsubo.
Team 3.
Yes, team 3.
Okay. It is nothing but pericarditis. Young patient having chest pain, and if you see there is ST elevations are seen in all the leads. Okay, and also the characteristic finding in acute pericarditis is your the ST elevation, which is concave upward. Whereas if you see in MI patient, this ST elevation will be convex upwards. Okay, so it's a classical ECG finding of a acute pericarditis. And how will you manage this patient? Takatsubu?
Sir, in this case, I would first of all, the patient would be leaning forwards. That would be the normal presentation of the patient. I would like to see that whether the pericarditis. First of all, I would like to see the cause, whether it is yes, it is uremic pericarditis or not. Finding cause is quintessential if I want to manage this patient. Then I will also go for the pain management of the patient as required. It is usually a self-limiting condition, so no as such management is required.
Yeah, if it is acute viral pericarditis, usually most common is viral, and it will settle within a week. Self-limiting, and you can give maximum NSAIDs. Okay. Yes. So this you have got it. Next question. Did anyone got it?
Sir, I would like to try this one as well.
Yeah, try it.
Sir, this is torsades most probably. Torsades
Torsades, excellent answer.
And sir, the cause can be both. It can be due to hypocalcemia as well as hypomagnesemia. Usually, hypomagnesemia is classically implicated in this case. But as the patient is having acute pancreatitis, I would like to say here that hypocalcemia can also be one of the cause here.
Hypocalcemia. Okay.
In this patient, we can see multiple morphology, and we cannot see any identifiable P wave, which is one of the characteristic of torsades, and IV magnesium sulfate is usually given as a drug of choice in this patient.
Drug of choice. Okay. And any other finding which is specifically seen here? I have shown an ECG, and following which torsade de Pontis is happening. So that means some trigger is there which is triggering this polymorphic BT.
Sir, the trigger here is hypocalcemia itself, because the patient is having acute pancreatitis. So what will happen is that it will chelate the calcium, and the calcium will go into stool. So the patient will have acute hypocalcemia.
Okay, what ECG finding is specific here for hypocalcemia? Any specific finding there?
Sir, the QT interval is shortened, but I would not say here that it is very specific finding in this case.
Yes. Here you can actually see inverted T wave, following which one more positive wave is happening before the T wave. So what is this possible wave here? Anyone?
Sir, is that the U wave?
U wave. It is a U wave. Who told?
Yes, sir. Me only, sir. Team Backward Super Team 3.
Yeah. So it is a U wave, which is classically seen in hypokalemia. And this U wave, this is nothing but this means that QT interval is slowly getting prolonged. in hypokalemia, hypomagnesemia, and this prolonged QT interval at one point it will end in torsade de Pontes, like polymorphic VTs. Okay, this is what is happening here. This is this is a must know ECG, like those who are handled with electrolyte disturbances. Okay, so team A will get 10 marks for identifying it as hypokalemia and also VT, and Takasubab team will get 10 marks for the first question, and also here also they have answered 5 for the mechanism seen. Okay. Can we go to the next question?
Excuse me, sir. This is Arun. Could you
Yeah.
please repeat, sir? I'm just marking the scores. So
Okay.
for Taki Twins, Team A is getting 10 marks
Yeah, 10 marks.
for the ECG one.
Yeah.
For the ECG one.
Yeah.
And Takutsubo Titans, team 3 is getting 5 plus 5.
5 plus 5 here, and also here also they have found the finding, so 15 marks.
15.
Yeah.
Okay.
Okay. Can we go to the next question? Yeah. Next is.
Excuse me, sir.
Yeah.
Sir, we had a doubt.
Uh-huh.
So, what is the criteria for passing? Like, will the question be passed to the next team, or anyone can answer?
It will be passed to the next team.
Okay, sir. Thank you.
Yeah. Next, second team, are you ready?
Yes, sir.
Yeah. Here is the ECG of a 60-year-old smoker with typical anginal pain since 3 hours, and his troponins were positive. His ECG is shown. What is the diagnosis, first of all, and what is the next step are you going to do for this patient? If you are more specific
Sir.
with the diagnosis, it's well and good.
Sir, can I try?
Yeah, which team? So,
Sir, I'm
two.
B team, sir. B.
Okay, come on.
Sir, in lead 2 and 3, there is an ST elevation, sir.
Lead 2 and 3.
Yes, sir.
Okay.
And I guess it should be inferior wall MI, like
inferior
STEMI.
wall MI.
ST elevated MI.
Okay. Inferior wall is seen in what leads?
Sir, 1 and AVL, I guess. Like there is a reciprocal. Yes, sir. AVL and AVL, I guess.
Okay. So
So
I'm going with inferior wall MI.
Yes, sir. Yes.
Okay.
Yes.
So next step, what are you going to do for this patient?
Sir, for the management, literally, I'm not having any idea, sir.
Okay. Okay, then. You attempted. Next, let's see. Patient, second question for you. Patient with a known case of squamous cell carcinoma of lungs suddenly starts to have severe abdominal pain, irritable behavior, and pain in the loin which is radiating to the groin. Cause of this, first part, and name of the finding shown in the ECG, second part. So you didn't introduce yourself. You are from?
Sorry, sir. Sir, I'm Pavan from Madurai Medical College, Tamil Nadu.
Okay.
And my teammate is Sriram Babu. He is also from the Madurai Medical College, and we have pre-final year students.
Okay. Good.
Rasmi, cause of this and name the findings.
Yeah, name of the finding.
Sir, can I answer?
First, let's give a chance for the team, which is.
Sir, it is tall peaked T waves.
Tall peaked T waves.
Yes, sir. In V4, in the arrow mark you showed V4 and V3.
Yeah.
So it could be.
Okay, what clue I can give here is see the clinical features. Patient with severe abdominal pain,
irritable behavior, loin radiating to groin.
What does pain in loin radiating to the groin means? It is due to?
Sir, involvement of kidney, like paraneoplastic syndrome.
Okay, excellent. Paraneoplastic syndrome. You got that. So, okay, paraneoplastic syndromes resulting in some kind of renal stones and severe abdominal pain and irritable behavior. So, what is the paraneoplastic syndrome causing these kind of features?
Sir, obstructive uropathy. Sir, it
Cause
could.
of it?
Sir, it could be like potassium excretion could be a great loss. So it could be an hyperkalemia. The cause of this could be an hyperkalemic.
Hyperkalemia.
Yes, sir. Because there could be an obstructive uropathy due to the
Okay.
paraneoplastic syndrome, and hence it could have been
Name of the finding is tall T wave.
peaked T wave, not just tall wave, like peaked T wave.
Okay. Okay. So for this question, your answer is inferior MI. Okay. We can now end this and let's pass to the next team. Do you have
Okay,
anything
sir.
contrasting with this answer?
Sir, yes. First of all, I would like to answer the second part.
Yeah.
Sir, here we can see there is a patient is suffering from squamous cell carcinoma. The patient is
Yeah.
having hypercalcemia as a result of squamous cell carcinoma, which is also indicated by renal. The patient may be having a renal stone that is presenting
Okay.
as loin to groin pain. So
Excellent.
the ECG is indicating Osborn waves. Maybe it point towards the Osborn waves, which is a clear-cut indicative of hypercalcemia in this patient.
Excellent. Excellent. Perfect answer. It is nothing but cause of this is hypercalcemia. As a this hypercalcemia results in this triad of abdominal groans, painful moans, and painful moans meaning cyclic moans they tell, because due to hypercalcemia, the calcium ions depositing on the parietal cells of your stomach, causing severe gastritis, resulting in severe abdominal pain, and also depositing on your limbic system, causing irritable behavior in the patient, and also depositing in your renal interstitium, causing obstructive uropathy, resulting in your pain in the loin relating to groin. It's a
மீட்டிங்ல
classic
இருக்கு நான்
triad
கால்
of-
பண்றேன்
Hello?
So, sir, now shall I answer the first part?
Hello?
சார் சார் கொஞ்சம் மைக் மட்டும் அப்படிங்களா ஒரு டவுட் வாகிங் சார் சார் இப்போ வந்து ஃபர்ஸ்ட் டீமுக்கு வந்து ஆல்ரெடி 10 பாயிண்ட்ஸ் நம்ம கொடுத்துருக்கோம்ல ஒரு
Okay.
கொஸ்டினுக்கு
Hmm.
இப்போ அதே டீமுக்கு வந்து திருப்பி 5 பாயிண்ட்ஸ் அவங்க பாஸ் பண்ணி ஆன்சர் பண்ணல அது கொடுக்கணுமா
கொடுங்க.
ஓ ஓகே சார் அப்போ ஃபர்ஸ்ட் டீமுக்கு வந்து 10 பாயிண்ட்ஸ் அடுத்த டீமுக்கு ஒரு 15 பாயிண்ட்ஸ் ஓகே சார் ஓகே
Yes, so it's a classical triad of hypercalcemia, and there is this Osborn waves which is seen in this ECG. Okay, so team 3 I think got both of them correct.
Yes,
So,
sir. Now the first part is remaining. I also want to try the first part.
yeah.
So, sir, here most probably it is lateral wall MI rather than inferior wall MI.
Okay.
I think it is one AVL, V5, and V6, and lateral circumflex artery is the artery which is involved.
Excellent.
The usual management of MI, firstly, it is done in 4 steps. We have to give oxygen to the patient if the patient is having SpO2 less than 90%. Usually this
Okay.
guideline varies, but in my hospital it is 90%. Then we have to
Okay.
give sublingual nitroglycerin. Then we have to give morphine to the patient if the patient is in acute pain. Now,
Okay.
then the definitive management comes. If the patient comes to me within less than 12 hours, I will go for PCI. Otherwise, I
Yeah.
will
So
not go
this
for
patient
PCI.
is since 3 hours. So what will you do?
Yeah, sir. In this patient, I will go for percutaneous intervention.
Excellent. It is within the window period, so you will take the
Yes.
patient for angiography followed by primary PCA. Okay. Excellent. So team 3 will be getting 5 plus 5, and also here also 5 plus 5. So all 20 marks for team 3. Okay. Can we go to the next question?
Sir, I have a doubt, sir.
Yeah.
What was the diagnosis for the second one?
This one?
Sir, yes, sir.
It is due to hypercalcemia.
Okay.
If you see like solid tumors, mostly from the lungs and bones, they release a protein hormone called parathyroid related hormone. Okay, it will act similar to parathyroid hormone and it will cause hypercalcemia. So this hypercalcemic triad is shown here.
Fine, sir. Fine, sir. I thought it was
Okay.
paraneoplastic was the diagnosis.
Yeah, paraneoplastic syndrome due to like resulting in hypercalcemia. PTH related peptide release. Okay.
Sir, need a mark distribution for this question, sir.
Yeah, for this team 2 won't be getting any marks, whereas team 3 will be getting all 20 marks.
Okay, sir.
So coming on to the third question. Patient complaining of critical anginal pain, ECG was taken. What is the next step in the management of this patient? Okay. ECG is taken. First subpart is what is the ECG finding seen here, and next subpart is what is the next step of management you are going to do for this patient. Team 3, you can introduce yourselves, both of them.
Hello, sir. I'm myself Om Shah. I am currently intern at BJ Medical College and Civil Hospital, Ahmedabad.
Okay.
Hello, sir. This is Yesh Ratwani. I'm also an intern from BJMC Ahmedabad.
Okay, good. So, what is your approach here for this ECG?
Sir,
Yeah.
to me, ECG looks apparently normal here.
Okay.
So there is
And-
mild elevation in leads V1 to V6, but I am not able to appreciate that much.
Okay. So, what will be the next step when you get this patient in your
Sir,
emergency?
I would like to, sir, TMT, I would like to have the patient TMT done, and
TMT.
cardiac markers also I would like to see.
Okay. So, immediate next step, do you ask the patient to go
Once
for
I see the
TMT
cardiac
or
markers, I
troponins?
would be sure that the patient whether has MI or not.
So, immediate next step will be your TMT or troponins?
The troponins would be my next step here.
Troponins. Okay. Okay. So, yes. So, next question. CKD patient on maintenance hemodialysis. This patient has missed his last 2 dialysis sessions and he developed a fatigue and weakness. ECG finding, what is the ECG finding seen here and what is the cause of this ECG finding?
So here, this condition, as the patient has lost 2 CKD sessions, the most dreaded complication of chronic kidney disease the patient has developed. The patient has hyperkalemia.
Okay.
And the ECG clues that I can find out in this patient is the patient is having tall peaked T waves. The patient has prolonged PR complex and widening of the QRS complex are the typical findings that I can make out in this case.
Okay, excellent. So, ECG finding is tall peak T waves as well as widening of the QRS complexes. And also we can see like cause is hyperkalemia as pointed out rightly. So you will get 10 plus 10 for this question. And also what is the ECG? It is nothing but a normal ECG. So what is the definition of MI? Myocardial infarction means even if when the patient has any features, first is your troponins must be positive. Okay, only when your troponins is positive, then you will see whether the patient is having clinical features as 2 of MI or ECG findings as 2 of MI or echo findings as 2 of MI. Then you will term it as myocardial infarction. Okay, so here first thing is to do for troponins to check whether it is really MI or myocardial injury has happened or not. So this is also pointed out rightly by the team C. So they will be getting 10 plus 10 and here also 10 plus 10, 40 marks, full 40 marks. Congrats. Can I go to the next question? Next team ready?
Yes.
Yeah. Okay. 40-year-old patient complains of chest pain since 3 hours and an ECG was taken for this patient. Troponin was found to be positive. Now, what is the next step you will do for this patient? And what group of drug prevents arrhythmias in these patients? So you can introduce yourself, team 4.
Hello everyone, I am Haura Patanwala from Sage GSMC Mumbai.
Okay.
And I'm Punika Patel, intern at Sage GSMC KEM.
Good. Try this question. First is, after seeing this ECG, what is the next step you are going to do for this? So it's a patient is having chest pain since 3 hours and troponin is positive. So what does this mean? Patient might be having what?
MI.
MI. Okay. So after seeing this ECG, what are your differential?
So the drug that prevents arrhythmias in these patients is lidocaine.
Lidocaine. Okay. And what is the next step you will do? What is the diagnosis? Any guess? Can guess.
So the troponins are elevated and there is chest pain. So it is MI.
MI. What type of MI is this?
Posterior wall. It looks like posterior wall MI because there is ST depression which is seen in V1, V2, V3.
Excellent.
So it looks like posterior wall MI.
It looks like posterior wall MI. So
And
can I
next step
confirm
will
posterior
be
wall MI
PCI
with?
करेगा ना? So next step will be PCI.
So
But
to
since 3
confirm,
hours, 3
yeah.
hours is no, not PCI, sorry.
Then the question what I'm asking is, here you are seeing the ECG and you are suspecting posterior wall MI. That was really a good suspicion. So now what is the next step you are going to do to confirm this posterior wall MI? What are you going to do?
So okay, we'll put 7 V8 and V9 chest leads.
Excellent, excellent. You should
Right
next
sided
step is you should apply what?
The right-sided leads, basically.
V7, V8 and V9.
V7, V8, V9, which is nothing but posterior leads. Okay,
Posterior
because posterior wall MI will have your reciprocal depression in the anterior leads. Okay, this is what the reciprocal depressions are seen here. V1 to V3. And also one more differential is also possible with this ECG. It can also be what?
Hello.
Hello? Hello?
Yeah.
Yeah. So it can obviously posterior wall MI or it can also be a NSTEMI. Can you understand? NSTEMI is nothing but ST depressions in anterior leads. Okay, so to differentiate whether it's a posterior wall MI or a NSTEMI, you are going to do this posterior leads, ECG of posterior leads to confirm whether it's posterior wall MI or not. Okay, that is right. So what group of drugs prevent arrhythmias? You are told lidocaine for this. Okay. Next. Second question, a 50-year-old patient was taken to the PHC with altered mental status since morning. On examination, pulse rate was 26 and BP was 80/60. ECG was done. What is the diagnosis first and what is the best treatment option for him? Patient with bradycardia with this ECG and patient also had symptoms like altered mental status. So it is a symptomatic bradycardia with this ECG. What will be your suspicion? Any guess?
वही लग रहा था।
क्या
So it looks like an AV nodal block.
AV nodal block, okay.
Um, block? समझ में नहीं आ रहा नहीं एम पैटर्न दिख रहा है इधर पे और यहाँ पे भी है. So the ECG is not clear actually. We are
Sir, can
zooming
you-
in, but then there's a problem with the
You're
image.
not able to see, yeah?
No,
one?
sir, it's not very clear. It is blurred actually. नेट का कुछ इशू है क्या?
It's clear to us, sir.
Okay.
नेट का कुछ प्रॉब्लम है क्या?
So just try telling what findings you are able to see in this ECG.
या सर मेरा एक मिनट ट्राई करके देख चला रुक जा पहले. अभी हो रहा है. यहाँ पे देखना ये एम और ये एम पैटर्न है वो एलबीबीबी वगैरह जो बोलते हैं.
What is the rate going on here? Is it? It is? Any guess for the treatment option? Best treatment option? What is the normal heart rate?
60 to 100.
60 to 100. Here, how is the heart rate?
It is like
How to calculate heart rate?
So
ECG?
in this ECG, every P wave is not followed by a QRS.
Excellent. Okay. So P wave is not followed by a QRS. So
is it third degree heart block?
okay. So best treatment option will be
ICD.
ICD. Okay. So
Sir,
you have
now I
told-
think we should pass the question. You have
Yeah,
given
we'll
enough
pass.
hints. Enough
We'll
hints you have
pass.
given.
Yeah. So who's the next team?
Team 4, sir.
Who's the next team? Team 4.
We are in team 4.
Academic assassins.
Next, I have to send to team 5, sir.
Yeah, team 5.
Yes, sir.
Team 5. Yeah, they have, for this first question, they are told the next step to do is posterior leads ECG. That is right. What group of drug prevents arrhythmias in these patients?
Sir, amiodarone.
Amiodarone. Okay. Then for this question, what is the they have told diagnosis is right? It is third degree heart block. What is the best treatment option?
Sir, atropine for bradycardia.
Okay. Followed best treatment option. If you give atropine, will third degree heart block revert to normal?
No, sir.
So best option will be the initial option is first is atropine you will give. Next final best option will be
Pacemaker, sir.
excellent. This is pacemaker. So this team 5 will be getting 5 marks. Pacemaker is the right option. It's not ICD. ICD is something which will protect from arrhythmias. Okay, when VT happens, it will give shock and it will defibrillate. Pacemaker is something which will pace the right ventricle and it will protect from complete heart blocks. Okay, so in this ECG, what finding you can see is it is a PP interval. If you see, it will be constant, and RR interval. If you see, it will also be constant. But every P will not be followed by a QRS. Okay, so this is a classical ECG of a third degree heart block where the only option of treatment is a permanent pacemaker. Okay, so 10 marks to team 4 for diagnosing it as complete heart block. And let's skip the and 10 marks for team 4 for telling it as posteriorly DCG. So let's skip this question to next team. What group of drug prevents arrhythmias in these patients? Team 6. I didn't know this question will be skipped like this.
Team heart attack.
On try.
Adenosine?
Adenosine. Okay. Let's go to team 1 now. Which group of drug prevents arrhythmias? Prevents. It's not treating arrhythmias. Prevents arrhythmias in these patients. Team 1. Any guess? In MI patients, which group of drug you usually give to prevent? It's also acting as a protector from arrhythmias.
No,
Team
sir.
1.
They told they don't know.
Okay. Team 2.
No, sir.
Okay.
Sir.
Team 3.
Sir, classically we give cardioselective beta blockers which act to decrease arrhythmia in these patients.
Excellent. It is nothing but a beta blocker. Beta blockers main action is, one is to reduce the heart rate and myocardial contractility, to reduce the heart load, and also it acts as a protector from arrhythmias. Okay. What you told is lignocaine and amiodarone are things which are used to treat the VTs which happen post MI. Okay. So 5 marks for team 3. Yeah. Can we go to the next question? Is everything sorted? Yeah. Team 6.
Yes, sir.
Yeah. You are from?
Sir, I'm Gayatri K.R. from Savita Medical College.
Okay, good. So your question is?
Sir, I'm Ashwika from Savita Medical College, sir.
Okay,
the second
good.
team.
Okay, second year. Okay. 35-year-old female comes to the emergency with complaints of palpitations. Her BP was found to be 108/60. Her ECG is given below. What is your next step of management, and what drug is the optimal first-line drug here? Can you see this ECG clearly? You can see clearly. So patient is having a BP of 108/60, and what is the next step you are going to do after seeing this ECG?
Sir, is it a supraventricular tachycardia?
Excellent. It is a supraventricular tachycardia. So what is the next step are you going to do for this patient?
Adenosine, sir.
Adenosine. Next step, will it be adenosine, or what drug is the optimal first line? It is obviously adenosine. What is your next step immediately after seeing PSVTs? Anything can you do before giving adenosine itself? Can you do something to reduce the heart rate?
Sir, we can do vagal maneuvers.
Excellent. It is vagal maneuvers, like you can press the carotid body. Okay. And this will activate your vagus nerve, and it can revert PSVTs in many settings. Okay, good. So you'll be getting 10 plus 10 here. Next question. A 60-year-old patient who had MI 1 year before and is now complaining of palpitations. BP is 80/40. ECG is shown below. What is the diagnosis and what is the next step?
Sir, ventricular tachycardia.
Excellent. Ventricular tachycardia. So what will be the next step?
Sure.
Synchronized cardioversion, sir.
Excellent. It is DC cardioversion you will give. Why? Because BP is low. Okay. So this team will be getting the entire 40 marks.
Sir, would we prefer synchronized cardioversion or asynchronized cardioversion in this case?
That depends whether the patient has pulse or not. Okay, when the patient is having pulse, synchronization is the best modality of treatment.
Okay, sir.
Okay, yes. Yeah, so that's it. Has it ended or one more team is left?
One more team is there, sir.
One mistake. Okay. Yes. So, 62-year-old chronic smoker who is a known case of COPD with multiple exacerbations, who has been on MDA Astalin and MDA tiotropium. This patient is recently complaining of palpitations and ECG was done. What is the finding and what will be your management? So, team 6, you can introduce yourself.
Sir, I'm Ananya and this is Rashmika from KMC Manipal.
Okay, good. One, try guessing this. What is the ECG finding here? And also, how will you manage this patient? You want to see in close though? This is a COPD patient. These are ECGs which you'll be routinely seeing when you go to the internship and as well as when you handle emergencies. Okay. So, COPD patient who is been on MDA Astalin as well as MDA tiotropium, complaining of palpitations now and has come to you, and this is the ECG. And some clues are also there within the ECG to help you answer. And how are you going to answer, manage this patient? Okay, just tell me what are those arrows pointing at?
S wave. Prominent S wave is there? I'm not sure.
Prominent S wave. S wave is negative deflection after a positive deflection in a QRS complex.
Prominent Q. QS.
What are those waves before the QRS? Enough clues have been given here. Okay, at least tell whether it's a tachycardia or a bradycardia.
Tachycardia.
Tachycardia. Whether it's a regular rhythm or an irregular rhythm.
Irregular rhythm.
Irregular rhythm. Okay. So
Sir,
next.
I feel you should pass, sir. By this way, everyone will get the answer.
Okay. Okay then. So only this level of clues I can give. Now try guessing.
Cor pulmonale. Hold on. Sir, is this cor pulmonale?
Answer? Okay. So management. Okay, then can we go to the next question then? Okay. Patient comes to the PHC. On examination, his pulse rate was 50 per minute, but he was asymptomatic other than few episodes of dry cough. ECG was done. So what is your diagnosis and what is the appropriate next line of management?
Sir, sinus bradycardia.
Excellent. Sinus bradycardia. So what are you going to do for this patient?
Atropine.
Atropine you are going to do. Okay. Then next for this, your answers?
Sir, is this cor pulmonale?
Cor pulmonale. Okay. Okay. We can skip this question to the next team. Pass. Team 1.
Sir, is it multifocal atrial tachycardia?
Excellent. It is multifocal atrial tachycardia. And how will you manage this patient?
Sir, in these patients, we have to maintain oxygenation and electrolytes must be balanced. And since COPD exacerbation is present, we have to manage that as well.
Okay. Why has this tachycardia happened in this patient? So finding your
So because
done
of
it
the
right.
beta 2 agonist is present, and beta 2 agonists are generally beta 2 agonists cause tachycardia, palpitations.
Okay. So in management, what are you will do?
So we'll have to hold salbutamol.
Salbutamol, okay. So and then what are you going to treat? This heart rate is going very high. So how are you?
So beta blockers.
Beta blockers. Okay. So for this, do you have any answer? Next line of management for this patient?
So if it is sinus bradycardia, then if it is asymptomatic, then it should be benign, and then we won't need any intervention.
Excellent. Many patients have sinus bradycardia actually. Okay, so not all needs treatment, and it's asymptomatic and its pulse rate is just 50, nothing to do. So team 1 has got right for this next line of management, 5 marks, and finding they got it right, multifocal atrial tachycardia. Shift now pass to team 2 to tell the management of multifocal atrial tachycardia. What drug you can give to treat?
So they skipped.
Okay, team 3.
Okay, sir. So as the patient is having multifocal atrial tachycardia, first of all, if we are able to find the foci, we can. If we are not able to find the foci, then we can give three class of drugs basically possible here. First of all, we can give either beta blockers or CCBs, that is verapamil or diltiazem can be given. Then other drugs.
I want you to tell beta blocker or calcium channel blocker. What are you going to prefer here?
Sir, class 2A antiarrhythmics can be tried in this patient. Basically, verapamil can be tried. Diltiazem and verapamil both can be tried. Sir, actually, flecainide or propafenone can also be tried in this patient. They also work
Any
equally
other
well in
drug?
MIT. Sir, apart from this, sir, sotalol can also be given.
You have already listed out all the antiarrhythmics, I think.
Sir, all work against MAT.
Any other drugs which you should avoid here?
So basically, we always learn that verapamil or
if
diltiazem is
you
the drug of
want
choice.
one drug, then what you will try?
Sir, verapamil.
Okay. Calcium channel blockers can be tried here. Mostly diltiazem or verapamil can be tried. And also one more drug what you can give is IV magnesium sulfate. Okay. And main thing is your beta blocker should be avoided. The two because of what? Patient is already a known case of COPD. So there you can't give beta blockers. Already the patient is having COPD exacerbation. And if you give beta blocker on the top of it, then it will further exacerbate his COPD. So you should just know that you should avoid Astalin and you should avoid a beta blocker, and you can treat with a calcium channel blocker like diltiazem or verapamil, and you can also give IV magnesium sulfate. Okay. Yes. So 5 points for teams C. Points are noted, no?
Yes, sir. Sir, actually, what's the point for team 6, sir? It's their own question.
Own question. They told ECG diagnosis sinus bradycardia is right. So 10 marks.
Okay, sir.
And here they didn't answer anything. So 10 marks for team 6.
Okay, sir.
Okay. Can you tell out the marks before we conclude the round?
Sure, sir. Sure, sir. As for now, team 1 has get 15 marks. Team 2 didn't score anything. And team 3 got 85 points. And team 4, 10 points. Team 5, 50 points. And team 6, 10 points.
Excuse me, sir.
Yeah.
Sir, team 4 here.
Yeah.
Sir, we gave 2 answers, right?
For?
That third degree heart block and
Third degree heart block, you told it right, and you told ICD. Na, ICD is not the treatment of this.
yeah, but posterior wall, am I the
Yeah, for that also. Yeah, for that you have got it right. 10 marks, so total 20 marks for team 4. Here they got it right.
I'll change. So team 4 got 20 marks.
Yeah.
Next step.
Sir,
Yeah.
team 5 answered that pacemaker answer, sir.
Team 5 I told to give 5 marks for that patient.
But for that, he didn't say that. He didn't add that mark, sir.
Okay. Yes, sir. After corrections, team 4 is getting 20. Team
Okay.
5 is getting 55, sir.
Okay then.
Yeah.
Okay. Now we'll go for the cardio bus round. Is everyone following till now? For this round, what I will suggest to is, is everyone having headphones with you? You can connect it on because we'll be having some audios also. I'll start it when everyone is ready. You can just tell a yes in chat box if you're ready. Everyone switch on your headphones and keep yourself ready. Let's go with the buzzer round. So who will be telling it to me? Vignesh or that who
So I
pressed
will
the
be
buzzer
telling you.
first? Okay.
I will be telling
Vignesh
you.
will be telling, sir. Myself, Arun will be taking care of
Okay.
our scores and other stuff, sir.
Okay then. Okay. So can we start? Every team is ready for this?
So 100 they are asking.
Yeah.
Sir, 2 minutes, sir.
Get ready faster. Is all your teammates here in the Zoom? Is anyone missing out? Just check one.
Yes, sir. Breathing scrubs teammate is missing.
May I know what the reason?
Sir, how many questions are there in this round?
Yeah.
Sir, how
many?
Questions. How many questions?
Questions here, I think buzzer, it will be 15 questions.
Okay, sir. Okay.
Ready?
Sriram Babu, please answer. Sir asked twice.
Yeah, if everyone ready, just tell.
So 100.
Okay.
Sriram Babu. Sriram Babu.
Yes, sir.
Why your teammate is missing, sir asked.
Sir, he is actually in the hospital. He's trying to connect, sir.
Okay. So you can start.
Yeah.
Sir, within what time we have to answer after buzzing?
Yeah, immediately who is telling, whoever is ready, just ask them to put a message. Like ready or something.
So message is considered as a buzzer here.
Yeah.
Put a thumbs up as a emoji as a,
yeah.
as a mark.
Just put a thumbs up. That's enough for us.
Yeah. Can we start?
Yes, sir.
Yeah.
So
So
excuse
rules of
me,
this.
just a second. Actually, if I open my box, the half screen, so I cannot see half screen. Please do it as reaction or something, or we can answer WhatsApp if everyone is okay.
Reaction,
reaction
I
can't
can't
be
monitor.
considered.
Can't be monitored.
Because if I
it
open
will
the
be
chat
random
box,
attempt.
my half screen is gone, so I cannot see anything.
But reaction can't be monitored. That's the problem.
Actually, are you using the PC?
I am using iPad.
Or can you type something like any alphabets or something to tell that you are ready?
Why can't we have a raise and whoever raises the hand first can be monitored by Arun in the participant list?
Okay.
First,
Yeah,
who
that's a good suggestion.
raised hand can be called out.
Okay.
Okay, sir.
Okay,
Fine.
Okay.
Yeah.
I'll monitor the persons who are raising their hands.
Yeah. You tell me like whoever is willing. Okay.
Sure. Vignesh, I will take care of it.
Yeah,
Okay.
so rules of the buzzer round. First is right answer, you will get plus 20. Pass is allowed, but past question, if right, you will have 10 marks. But if you answer wrong, there is negative marking of minus 10. And past, if it is a past wrong answer, a team already told wrong answer, and if you, that question is passed to you, and if you answer again as wrong, then you will have a negative of 20. Okay. So can we start? First question, ready everyone? Okay. Can I start? First question. Yeah. So 10-day post antiretroviral MI, patient develops refractory heart failure and patient is in shock. On auscultating the left lower sternal area, this was found. What is your diagnosis? So everyone start hearing this auscultatory finding and try telling what is the diagnosis happening here. I'll play it once more. A patient of myocardial infarction, anterior wall, 10 days before, the patient now develops refractory heart failure and shock. On auscultating the left lower sternal area, this was found. MI patients, that too in this particular time graph, okay, has anyone raised hands till now?
No one, sir.
Okay. Katsuba has raised.
Katsuba is right.
Yeah, you can answer it.
Turn on your mic.
Answer?
Actually, you are
Sorry,
muted.
sorry. Hello, sir. Now am I audible?
Yeah.
Yeah. So, sir, the patient may be having ventricular free wall rupture because as I can see the patient is in profound shock. Also, the ventricular free wall rupture would present as a mid systolic murmur.
Yes.
So that looks as the case here.
Excellent, excellent. You are team 3 now?
Yes, sir.
Yeah, this team will be getting the entire 20 marks. Actually, it's more specifically, if you want to tell, it is ventricular septal rupture. Okay.
Yes, sir. Ventricular septal rupture.
If VSR has happened, this is a dreaded complication to be kept in mind in a post MA patient. The septum can rupture anytime, and this can result in patient having left to right shunting, and the entire pulmonary blood flow will be increased at a stretch, and this will result in pulmonary edema. Even after treating with Lasix, diuretics, and bypass support, patient will never come out of it. Okay, so auscultation is most important in post-anterior MA patient. But if you get this kind of systolic murmur, pan-systolic murmur, then it's diagnostic of VSR, ventricular septal rupture. Okay, can you go to the next question? So a 3-year-old baby with this feature on auscultation. Your diagnosis: a 3-year-old baby with this feature on auscultation. I'm going to play the audio. Someone has raised hands. Who is it?
No one, sir.
The sound is not
No
clear,
one, sir.
sir.
No one.
Okay.
Actually, you have to wear the headphones. It's proper.
Now?
It is actually clear.
A 3-year-old baby with this finding on auscultation. Auscultation over the base of the heart. Takatsuba has
Takatsubo
raised
has
hands.
raised
Takatsubo titles as raised their answer.
Yeah. Okay. What is your answer?
Turn on the mic. Sir, turn on the mic. Please.
Hello.
Yeah.
Yeah.
Sir, I can make out a pan-systolic murmur.
Okay.
Also, there is, I think, rib notching is visualized. So maybe this is a
No,
case of PDA.
don't
The
think
diagram that you showed, sir.
No, diagram is not related to this. Sorry.
Sir, I think in second or third rib there is notching at the inferior.
No, diagram is not at all related to this.
Sir, can I try?
Sir, this is PDA most probably. Patent ductus
Your
arteriosus.
answer is PDA. Okay. So what next team? What do you want to try?
IITK or academic assent.
Sir, I also wanted to say PDA only, sir.
PDA. Okay. Okay, I think for this question you can give both the teams because I was able to see both raising. So let's give
But
marks.
sir, team 3 has risen first and told the answer first, sir.
Okay. Okay.
Yes,
then.
sir.
It will be go to the team 3.
Okay. Next question. A 65-year-old chronic smoker with this sign.
Sir, sorry to interrupt. 1 minute. Academic assistants, please unraise your hands before.
Lower your hands.
Lower your hands.
Yeah.
Okay. A 65-year-old chronic smoker with this sign. Old patient, chronic smoker with this sign. Anyone?
Team 3 has raised their hands, sir.
Yeah. Can answer?
Please unmute yourself.
Sir, this patient is having this sign is known as Frank sign.
Excellent. It is.
And this is diagonal crease in the earlobe.
Crease in the earlobe.
Also
So
known
this
as Frank
crease in
sign.
the earlobe is diagnostic of Frank sign. This means what? What does this mean?
Sir, this means that the patient is having one of the coronary artery diseases. The patient should screen for have cardiac markers get done and a ECG get done.
Excellent. It is nothing but a marker of atherosclerotic heart disease. So it should be screened further. Okay. Yes. So team 3 will get 20 marks.
20 marks.
Can you go to the next question?
Yes, sir.
This group of organism is involved in pathogenesis of atherosclerosis. I want you to answer what is the specific organism which is proposed that this organism is involved in the pathogenesis of atherosclerosis. 2 picks to help you. What a microbiological organism is also implicated recently that it is also involved in pathogenesis of atherosclerosis. Breathing scrubs has raised.
Yes, sir.
Can answer?
So it's chlamydia pistachii, which is causing the myocarditis.
Good. It is nothing but chlamydia. Okay. Chlamydia is actually is nothing but the pictures are showing that it is parrots or psittacosis. Okay. And also this chlamydia pneumoniae also causes this kind of pneumonia, which is also called as Walker's pneumonia, where the patient will be having fever with atypical type of will not be a typical pattern of pneumonia will be seen in these patients. And they have proposed that chlamydia pneumonia is involved in pathogenesis of atherosclerosis. So this team will be getting 20 marks. Can you go to the next question?
Yes, sir.
Yeah. Artery marked is. So I want you to answer this artery, this big artery which is coming out, and what is the MI which is possible with its acute occlusion. I want you to answer this artery which is coming out. This artery which is coming out, and if this artery is acutely occluded, then what will happen? Heart attack has come out. Come on.
Left anterior descending artery, inferior wall MI.
Inferior wall MI. Left anterior?
No, left anterior descending.
And what is the MI you can guess?
Anterior wall MI.
Anterior wall MI. Okay. So minus marks will be there. Keeping your team's name as heart attack. You missed this.
Next one, Gayatri KR has raised the.
Okay, I can tell.
Sir, it's left anterior descending artery and anterior wall MI.
Okay, again, same negative mark. So it will be minus 20 now for this team. Next, Taki twins.
Sir, it's right coronary artery.
This?
And about MI, I'm not sure.
Okay. Okay, you can give 5 marks for this. Right coronary artery occlusion will result in inferior wall MI.
Sir, can I answer now?
No, it's ended.
No.
It's told already.
Ended.
So only half the answer has been told, so 5 marks.
5 marks, yes.
Which team?
Taki twins, first team.
Taki twins.
Oh, first team. Okay.
Yes. Next, a 45-year-old tall male with unequal pulses on both arms with severe tearing type of chest pain. And this is a CT image. Takatsuba Titans has
Takatsuba is, yes.
Yes, sir. The diagnosis in this patient is aortic dissection. As the patient is having severe tearing type of chest pain, the patient mostly has Marfan syndrome. Marfan syndrome has aortic dissection as one of the cause of death. The patient will also have unequal BP in both the arms and pain acute radiating to the abdomen and back, which is classical of aortic dissection.
Excellent. So plus 20 for team 3. It's a aortic dissection. Next, let's see who answers this. Patient on digoxin, what are you going to do after seeing this change in the ECG? Extracardia has raised.
Extracardia, turn on your mic and announce.
So it is Salvador Dali sign which is seen, the reverse tick sign which is there.
Excellent. So what are you going to do after seeing this change?
And lignocaine is the drug of choice for.
Lignocaine is a drug of choice for?
Digoxin-induced arrhythmia.
Arrhythmia. Okay.
Hello.
Next. Yes.
Hello, are we audible?
Yeah, you are audible.
Yes.
Yeah, so lignocaine is the drug of choice for digoxin-induced arrhythmia. So.
Okay. Okay, then. Next. Takatsuba is also raised. Let's see their answers.
The patient is having Salvador Dali sign as they answered. This indicates the patient is having digoxin toxicity. First of all, what we would do is that if there is any precipitating factor for digoxin toxicity, for example, hypokalemia or hypercalcemia, we would correct it. We would also see if there is any other drug interaction. And if in the acute condition, we will give digipine, which would just flush away all the digoxin excess and we would get normal ECG again.
Okay. Then any other teams has raised apart from these two? Any other answers? No.
Only from Dextrocardia and Takatsuba only.
Okay. First part is right. it is nothing but due to digoxin, this change is happening, and the sign they have mentioned it is right. So after seeing this sign, this is a sign which is needed after giving digoxin. It is characterized as digoxin effect. Okay. When a patient is on digoxin, this sign will be there. Digoxin toxicity is different from digoxin effect. Digoxin toxicity will be having it will be resulting in like bidirectional ventricular tachycardias or DTs, or digoxin toxicity resulting in your conduction disturbances or atrial arrhythmias. All these arrhythmias are possible with digoxin toxicity. And this sign is seen, then that means it is just digoxin effect. That means whatever digoxin you have given, that has systemically reached the circulation and has reached the heart, it has caused this effect. This is the effect which we need after giving digoxin. It is not something to be scared of. Okay, so the first part was right. For which team answered digoxin effect?
Team 4, sir.
Extracardiac.
Okay, so they might get 10, but the what to do after seeing this change is like nothing. It's just conservative only. Okay.
So what about the team 3, sir?
Yeah, then negative marks for telling digoxin toxicity.
Sir, we answered the first part, and that we answered it correctly.
Meaning?
Sir, the first part, what is the sign? What is the sign that we
Yeah, that
answered
sign
correctly?
though, previous team itself answered, no? Previous team itself answered that name of the sign.
But sir, I think precautionary measures can be taken because we have to avoid digoxin anyhow if we are giving digoxin.
Like this effect is something which we need to see after giving digoxin. Once the patient is digitalized systemically, this effect will be seen. So all these
But sir, it
precautions,
also
what you're telling
indicates
is right.
toxicity.
But only when it results in toxicity, you should be doing something. Like what you're telling was right. I was expecting
Sir,
this.
should avoid negative, I think, at least.
Meaning?
What we told was precautionary measures, so you should avoid giving negative dose. We did not do anything wrong.
Like the main point was missing.
But it's not up to the
Okay,
question
sir.
he asked, right?
Okay, sir, no issues.
Okay. Okay, next question.
Team, kindly please don't argue with our judges, please, sir.
Okay.
Okay, sir.
Finding in the arterial waveform. You have inserted arterial line for this patient, and I want you to focus on this area, this red segment, arterial waveform, and the patient is having a BP of 84/60 and tachycardia is going on. And what change in the arterial waveform is happening in this patient? Let's see if someone raises hands. If not, I will give you a clue also for this. There's something in bedside we can see for these patients. It is having
academic assessments raised their hands.
Good.
Sir, pulses paradoxical.
Excellent. It is pulses paradoxes. Why? What is happening here in this question?
Sir, there is ventricular dysfunction.
Okay. Then?
Sir, beat to beat variation is there between atria and ventricle.
Okay. But the answer what you're telling and what correlation is actually wrong, but finding you have answered it rightly. What is happening is, if you closely see, this is the inspiratory curve. Okay. So here, when the patient is doing inspiration, what is happening to his BP? It usually during an inspiration, the BP falls, systolic BP, but it falls to less than 10 mm mercury. But here, if you see, during inspiration, the systolic BP is falling to more than 10 mm of mercury. Okay. This is called pulsus paradoxus. Is seen in cardiac tamponade, and like patients who is having pericardial effusions, you can do arterial line monitoring, and if you find this sign, then that means the patient is going into cardiac tamponade, and emergently you should do pericardial census for this patient. So this is a arterial waveform finding. Okay. Its pulse is paradoxus.
So how much points we can give to them?
20 points you can give. Finding only.
Okay. Okay.
Anyway, they answered it right. Okay. A 70-year-old male with atrial fibrillation and recurrent episodes of heart failure and tingling sensation in the thumb and lateral 2.5 fingers. Diagnosis. And this high finding I have shown.
Dextrocardia has raised their hand, sir. Team 4.
Amyloidosis.
Excellent. It is amyloidosis, 20 marks. For amyloidosis, here it is causing a restrictive cardiomyopathy, which is causing atrial fibrillation, and their patient will be going into heart failure again and again. Even though ejection fraction will be normal, but due to restriction in the diastolic relaxation, patient will be going into heart failure. And why is the tingling sensation is happening in thumb and lateral 2 fingers in amyloidosis?
Neuropathy.
Involvement of
Neuropathy.
neuropathy. Okay.
Radial nerve.
Okay. It's nothing but carpal tunnel syndrome and also polyneuropathies all are possible in this patient. Okay. So 20 marks for this thing. Next.
Okay.
Multiple episodes of fever in IV drug abuser. What phenomenon is this?
Dextrocardia has raised their hand, sir.
Answer it specifically. What phenomenon is this?
So the patient is IV drug abuser, so most probably infective endocarditis.
Okay.
And the finding is rod spots seen.
Okay. So what phenomenon is this? Infective endocarditis.
Immunological phenomenon. There is
Excellent. 20 marks. Immunological phenomenon. So rod spots, 20 marks for dextrocardia.
Team 4.
Yeah. Next. Sign shown is
Dextrocardia has raised their hand, sir.
Muller's sign.
Seen in aortic regurgitation.
Aortic regurgitation, 20 marks. There's nothing but pulsation of the uvula can be seen here. Muller's sign, severe aortic regurgitation. Sign shown. Next question. What finding?
Yes, dextrocardia has raised.
Okay.
Sir, it is dancing carotid seen again in aortic regurgitation.
Carotid. Okay. Next who was answering it?
Another one, Takatsubo, sir.
Takatsubo. What are they trying to answer? Negative mark for who answered it first as dancing carotids?
-10.
Dextrocardia.
Okay.
Takatsubo, Team 3, you have raised your hands.
You want to answer anything?
Actually, you have to unmute yourself before.
Sir, is it demused sign?
Demused. No. Demused is nothing but what?
Head nodding, sir.
Head nodding, but we are focused here specifically in the neck.
Sir, is it raised JVP? The ventricular pulsations are visible, is it?
Sir, can we consider the first answer as wrong and can I put it as negative?
Yeah, negative. First answer is negative. Next option, next who told us? Someone told us.
That's it, sir. Only 2 has raised the answer.
Okay, that was also negative.
We can move on next question, sir.
Okay. Next, sign shown here. Is not playing. We will go to the next question. Okay. So here is this.
Going to 14 questions.
Yeah. We'll go to this question. A patient with this finding having subependymal nodules in lateral ventricles with developmental delay, and patient is having cortical cyst in the kidney and heart tumors. So what
Takatsubo has raised their
was,
hand, sir.
yeah, you can answer.
Sir, this is tuberous sclerosis and cardiac rhabdomyoma is the finding in the heart.
Excellent. It is nothing but constellation of features is tuberous sclerosis and rhabdomyoma, sarcomas and rhabdomyomas are possible. 20 marks.
Yes.
Next, if this feature is seen, then no need to see for major or minor criteria for rheumatic fever. True or false? Let's see who raises the hands here. This.
Takatsubo has raised their hand. Second, at dextrocardia.
Okay. You can answer.
Could you please
Please
unmute
turn on
yourself,
mic.
Takatsubo?
Hello. Sir,
Yeah.
this is
Yeah.
Sir, this is basically chorea. Sydenham's chorea is seen here. The answer would be false because in order to diagnose infective endocarditis, we have to have at least of one major plus 5 minor or 3 major criteria to diagnose it as infective endocarditis.
Okay. So, is it true or false?
So it is false.
False. We need one major and how many minor?
Sir, if there is only one major, then we need 5 minors. All the 5 minors should be met.
Okay. Or
We
how
need
many
3
major
majors and
criteria
3
we need?
minors.
Okay.
3 majors we need.
Okay. So any other answers apart from this?
It's true or false for me, sir.
Dextrocardia.
So first team has told it to be false.
False.
Any other answers apart from this?
So I feel like it's either true or false. The first team has told false, so
then negative marks for the first team. So what is this? Sir. This is nothing but pronated drift, which is seen in Sydenham's chorea. They diagnosed Sydenham's chorea right, but what you guys need to know is only if Sydenham's chorea is there, it is an exception in the diagnosis of rheumatic fever. Okay, if Sydenham's chorea is there, then recently they have added exceptions to rheumatic fever. In that, first thing is this, because Sydenham's chorea doesn't happen during episodes of acute rheumatic fever. Most of the Sydenham's chorea happen after at least 3 to 6 months after the episode of rheumatic fever. So till that time, patient might not have remembered also what all happened before 6 months, and fever with subclinical carditis might have present. So chorea is a exception to diagnosis of rheumatic fever. So if this feature is seen, then you must diagnose is to be rheumatic fever, and if you work up for it, and it is an exception for diagnosis of rheumatic fever. So its option answer is it's true.
okay, sir. So can we skip the 13th question?
Yeah, I'll have one more question for that.
Okay, sir.
Okay. So yes, this one. Diagnosis.
Dextrocardia has raised their hand, sir.
Sir, A, atrial flutter with variable block.
20 marks for dextrocardia team. It is atrial flutter with variable block. Okay, so that's it with the buzzer round. We'll go to the next round. So you can read out the marks in the meantime.
Yes, sir. I'm just calculating, sir.
Okay. So are you finding it very difficult, or is it okay?
So by the end of second round, team one scored 5 points in this round. So total of 20 marks for team one.
Okay.
And team two has scored 20 marks in this round. So overall score of 20 they have scored. And team three, Takatsubo, team three has scored 1, 2, 3. 40 marks in this round. So overall of 125. And team 4, Dextrocardia. Dextrocardia scored 80 marks in this round and total of 100. And team 5. Team 5 has scored 0 marks in this round. They answered one correctly and they answered a past question. So answered wrong in past question. So it's considered 0. So overall they took 55 marks. And team 6 got one minus 10 marks. So overall they're getting 20 minus 10, 10 marks for team 6. So these
Okay,
are the
so
results for the.
which team is leading now? That thing
As for
is
now,
this.
Takatsubo is leading, sir.
Okay.
With a score of 125.
Okay, so
Followed
that
by
team will be
Dextrocardia 100, sir.
okay. So we'll first throw the question for expert team. Clinical case round. So rules is each will be a clinical case. It will have auscultation audios and also video recordings of the case also and also physical science. So you will be having 5 sub questions in the case. Each will be carrying plus 20 marks. And for wrong answers, you will be having minus 10. And all questions will be shown before coming for the answers. Okay, so all 5 sub questions will be shown to you before coming to your answering part. And passes are allowed at the end of the session after completion of that particular team. And right answers for the past questions, you will be having plus 5. Okay, can we start? Team 3.
Yes, sir.
Yeah. So first case for you. A 19-year-old male presents with progressive fatigue, episodes of syncope, and breathlessness on lying down on one side. He has skin lesions. His parents mention he has had learning difficulties and he has had a weight gain of 5 to 8 kgs in the last month alone. His weight is 78 kgs. Freckling is seen in the axillary and inguinal regions. No signs of puberty despite 19 years. He's having a BP of 170/100. Okay, so now let's see. These are the skin findings which we're seeing here. This is the abdominal finding, and this was the findings over the back. So let's start with the questions. First is, be ready to auscultate this. Nothing to do with that picture. Just auscultate. And try guessing what murmur you can appreciate in this. And next, we are going to do echo for this patient. This is the echo for this patient. So this is the echo. Next, third question is, what is your diagnosis after seeing this finding and what is the cause of this finding seen in this patient specifically? Okay. And next question, what is the finding which is seen here? Cutaneous finding, which is also seen here. And the fifth question will be final diagnosis after seeing the entire features.
Okay, sir. Shall I start?
Okay, you are trying it?
Firstly, I will go part by part. Sir,
Okay.
this is basically what we can
Sorry
say
for the
is one is
interruption.
Yeah.
Now team 3 is telling, sir.
Yeah.
If he is not telling the answer, we can pass to single one team, sir.
Yeah, one
team. So we can finish the question within the team 4, sir.
Okay, okay then.
You can continue. Takatsubo,
Okay,
you
sir.
can
Shall I
continue.
answer?
Yeah.
So basically the tumor I came across in that is tumor plop is heard, and one finding is atrial myxoma. In this
Okay.
case, that brings down the overall diagnosis of it to Carney's complex. We
Okay.
basically another image you show was of blue nevi.
Okay.
The gene that is affected is PPA1RK1. That is the gene.
Okay.
One alpha. That is
One alpha.
usually
Okay.
the
What is
gene,
the
and there are
diagnosis?
two. Sir, basically we have something known as Carney's complex,
Okay.
and there is something known as Lamb syndrome. Okay, the Lamb syndrome refers to lentiginous atrial myxoma and
Okay.
blue nevi. That is
Okay.
what we have two syndromes. We have Lamb syndrome and we have Name syndrome. So the Lamb syndrome, I answered it because of atrial myxoma and blue nevi.
Blue nevi.
Whereas the Name syndrome has nevi, atrial myxoma, myxophyte neuroma, and aphelis. So both are interchangeable.
Okay. So you got this one right. First is tumor plop and the diastolic murmur. Next is the atrial myxoma, which is seen in this echo finding. Got it right. So what about this question? What is the diagnosis after seeing this finding, and what is the cause for this? And for the fourth finding, you have got it right. It is blue nevi. And final diagnosis also, you got it right. It is Carney's complex coming under Lamb syndrome. Everything is right. Only this is missing. And clue also I'll give.
Sir, basically what happens is there are endocrine manifestations as well of these diseases, which are seen as stria in the abdomen. So they are basically those itself.
So what endocrine disturbance can be seen here?
Sir, Cushingoid features are seen.
Cushingoid features. So patient is having weight gain, hypertension, and also this Cushingoid features are seen. It is due to the endocrine disturbance. It is due to case of pigmented adrenal hypertrophy. Okay, hypertrophy which is happening in this case of Carney's complex, which will result in Cushing syndrome. Okay, you got it all the things right. So you'll be getting total of
100 marks, sir.
100 marks. Yes. So next team, are you ready?
Team
Yes,
4
sir.
dextrocardia. Please be
Yes,
ready.
sir.
Are you ready?
Yes, sir.
Yeah. So case 2 for you. 21-year-old tall male presents with progressive fatigue, orthopnea, and leg swelling. On examination, he has a hyperdynamic displaced apical impulse and a S3 gallop. Chest X-ray shows cardiomegaly and pulmonary congestion. Okay. So first is X-ray, and this is the X-ray of this patient also. Just as a supportive finding for yours, it's not a question. So what is the inheritance pattern which is seen in this patient? So all those gray shaded areas are those patients which are affected, and all those white areas are those which are not affected. Squares for male and circles for females. So what is the inheritance pattern going on here is the first question. Next is, what is the ocular finding which is seen in this patient? Next, and third is, this is auscultatory finding. You can auscultate now. Next, this is the echo finding. So I'm just playing it. This is after applying color and 4-chamber view. And this is after applying color in 4-chamber view. So since you guys are new, I'll just tell in this echo 4-chamber, these chambers are the left-sided chambers, and this will be the right-sided chambers. Okay. Yes. So next, last question, cause of back pain and headache in this patient. What is the cause or back pain and headache if it happens in this patient? These are the 5 questions you'll be having. If you want to replay the audio, you can ask or you can go to the answer.
Sir, can you replay the audio?
Yeah.
Okay, sir.
Yeah. Start answering.
So this is Marfan syndrome.
Okay.
And autosomal dominant inheritance.
Dominant inheritance. Okay. Next. So why are you telling it as dominance after seeing this pedigree?
So because there is no skipping of the generations,
Good. Then
and so it is dominant, and then like it is not X-linked, obviously, because the female would have been affected, वैसे,
excellent.
so
Okay. Good. Autosomal dominant. Next, what is the ocular finding?
superotemporal dislocation of the lens.
Excellent. Ectopia lentis with the superotemporal. Next, osculatory finding.
This is pansystolic murmur.
Okay.
Seen in case of mitral regurgitation.
Mitral regurgitation. So what is the echo finding?
The echo finding also shows mitral regurgitation.
Mitral regurgitation. Can I get a more specific answer? Like why is mitral regurgitation happening?
It is acute MR.
Because there is mutation of the fibrillin gene, so like the elastic fibers which are present, so they are defective here. So like the structure of the heart will be affected, and there will be regurgitation of, like, there will be what we say, like incompetency of the mitral valve, basically, which will lead
Okay.
to the
Anything
regurgitation.
specific after seeing this valve finding? Okay, you are telling it as mitral regurgitation, severe MR. Okay. Then what is the cause of back pain and headache in this patient? Okay, I think almost 4 you got it right. You can skip to the next team if they want to answer this, or else we'll change to the next.
We'll like to pass. We'll like to pass, sir.
Okay. Next team is the next team ready to answer
Team
this?
5. Team 5 academic assassins.
Sir, because
You
of
want to try?
scoliosis.
Scoliosis, no. I've specifically marked these structures. Due to these structures, any possibility of back pain? The elastic fibers are defective not only in your valve structures but also in these areas. Okay, this I will answer. This is nothing but dural ectasias, which is possible in Marfan syndrome, which will cause recurrent headaches and dilatation of the dura mater. Okay, but 4 questions you have got it right. So 80 marks for this team. And here specifically you can see this. Specifically, you can see the mitral valve which is not closing properly. Okay, the anterior mitral leaflet is collapsing into the left atrium. So it is mitral valve collapse resulting in severe MR. Okay. Can we go to the next team? 80 marks can get for this. Is next team ready?
Next team 5 academic assassins, please.
Yes, sir. Yes, sir.
Yeah. Case for you is 32-year-old man presents with sudden onset right-sided weakness and slurred speech. He has history of intermittent fever, night sweats, and weight loss for past 3 weeks. He is a known IV drug abuser. On examination, he is febrile with a wide pulse pressure and bounding peripheral pulses. Neurological examination confirms right-sided hemiparesis. CT shows an ischemic infarct in the left MCA territory. Blood cultures are pending. So for this patient, I want you to answer the findings. What are the findings seen and phenomenon seen in each of the findings? This first part. Next is auscultatory finding of this. Next is the clinical sign seen here. Seen in one of our patients only. Then treatment of choice in this patient. What is the empirical antibiotics you will be preferring for this patient, and what is the management option for this patient? And last question. So all of the following need secondary prophylaxis for the condition shown, except A is tooth extraction in a patient with history of treated infective endocarditis. B is upper endoscopy in a patient of corrected tetralogy of Fallot 10 years before. C is routine dental cleaning in a patient in whom AST device closure was done 3 months before. And D is dental abscess drainage in a patient with post-mechanical mitral valve replacement. So all the following patients will be needing secondary prophylaxis, except whom won't be needing it. Okay. Yeah. Are you ready? Anything you want to see again?
Yes, sir. Can you show it again?
Which one?
Sir, this one, can you play?
This is
Sir, so it's infective endocarditis.
okay. So the findings, what are the findings you are able to see here?
Sir, the findings are clubbing of fingers,
Okay.
palmar lesion.
What lesion?
Palmar.
Palmar. What is the name of the lesion called?
Janway lesion.
Janway lesions.
Then conjunctiva, like petechiae.
Petechiae, good. Then what is this? Snails?
Osler notes, next one.
Osler
right
notes. Okay. Yes, this is you are telling it as
Then
Osler.
that's also, and soles of the feet also Janway lesions, sir.
Okay, so these are Janway lesions.
Then pallor of the palm.
Okay, then what is this sign which is seen in the nails?
A clubbing of fingers, sir.
Clubbing. Okay. So what is the phenomenon?
Petechiae, sir. That one petechiae.
Petechiae. Okay. So what are the phenomena seen here? What is due to what phenomenon?
1 minute, sir. What, sir?
It is due to what phenomenon?
Anemia, sir, like chronic later anemia.
Okay. Then
1 minute, sir.
Janway lesions are seen due to what? Why? What phenomenon?
Sir, immunological phenomenon.
Immunological phenomenon. Okay. Osler's notes?
It's also immunological phenomenon.
Immunological. Okay. Then petechiae?
Petechiae vascular phenomenon, sir.
Vascular
Sir,
phenomenon.
Osler's notes also vascular phenomenon.
Osler nose, vascular phenomenon. Okay. Then next. These are the areas which will be confused. So, one question. Okay. Oscillatory finding.
Aortic regurgitation.
What murmur you are able to hear?
Regurgitation murmur.
What murmur?
Regurgitation murmur, sir.
Why is it in the systole or diastole?
Diastolic murmur.
Diastolic murmur, early diastolic murmur. And what is this finding? What is this finding in aortic regurgitation called?
Durozois sign.
There is a sign. And any other names?
No, sir.
How was this audio simulated? Next, what is the empirical antibiotics? You are suspecting infective endocarditis. What empirical antibiotic should be given? That too, this patient is a case of IV drug abuse. So, what empirically, what are all the
Sir, for Staph aureus, we can give vancomycin.
vancomycin and combination with what? Some other agent?
Gentamicin.
Gentamicin, excellent. Vanco, Genta you can give, Genta can cover the enterococcus pieces also. So, permanent management, what you can tell for this patient?
Valvular replacement, sir.
Aortic valve replacement after stabilization. Okay. This. So, this you have answered it right. What about this question? All need secondary prophylaxis except who don't need secondary prophylaxis in this patient.
Sir, option B, sir.
Option
B.
B, dental abscess drainage.
No, sir. B.
B, upper endoscopy.
Yes, sir, that one.
Excellent. That is also the right answer. So almost all you got it right, except this. For
Should I
this, you can
explain
give
this again, sir?
like
No, like, you have any doubts in what we said, sir? Like any confusion?
no, you are told almost everything right except this findings. Let's pass to the next team. If they are able to tell the findings, or else we can conclude.
Sir, we said, sir, like Osler notes,
Findings you are
January.
told, phenomenon you have mismatched.
Like
completely.
Osler notes, it's immunological phenomenon, sir. For January lesion, it's vascular.
Vascular or these two findings?
Which one, sir?
Petechiae?
Petechiae, sir. Petechiae vascular.
Vascular.
The next one, sir.
This one?
Adukku? That's clubbing, sir.
Okay, this is not clubbing actually. These are splinter hemorrhages. Okay, almost you have got it right. Like we can end this question here itself. Like these are splinter hemorrhages. Okay, which is also a vascular phenomenon. Petechiae, vascular phenomenon. Janvi lesions are vascular, whereas Osler's notes are immunological phenomenon.
Okay, sir.
On oscillatory finding, this is the early diastolic murmur. Actually, here it can you can hear throughout the diastole, telling it as severe AR. And this is the nothing but pistol shots femorals, and also systolic compression will lead to your trop sign, and diastolic compression will lead to your Durose's sign. Okay. And this antibiotic of choice, you have told it right, and management also valve replacement. And this also you have told it right. So you can give 90 for this team. Can we go to the next team?
Yes, sir. I'm giving 90 to this team.
Who's the next team?
Team 6. Heart attack.
Okay. Yes.
Team 6, are you ready?
Ready?
Could you please unmute yourself and
Yes, sir. Yes, sir.
Okay.
Yeah.
You are which years? Team 6?
Sir, final year.
Both are final years?
Yes, sir.
Okay. Okay. Mr. Rajesh, a 42-year-old man, presents to the emergency with acute abdominal pain radiating to his back. He rates the pain as 8/10 and notes it started suddenly this morning after a night of binge drinking. He has history of poor controlled type 2 diabetes and is on metformin. On examination, he is febrile, tachycardic, and has mild epigastric tenderness without guarding or rigidity. No xanthomas are noted. And lab results showed a creatinine of 0.9 and amylase levels were raised 540 and lipase levels were 1100. And urine and blood for ketones were done, they were negative. Glucose levels was 280, LDL 120, HDL 25. Okay. This thing. Next is cutaneous findings are these. And this is the, after collecting his blood, this finding was seen after keeping it in the in this container. We can see this blood to be changed into this kind of finding. Okay. And next is, what is the most likely cause of his acute presentation? And what is the most appropriate initial management of Mr. Rajesh triglyceride levels in this acute setting? And which lipid pattern is most characteristic of this condition, type 5 hyperlipidemia? And follow-up of lipid panel has been done. And what is the best long-term pharmacological therapy for this patient? And they have high risk of developing atherosclerotic coronary artery disease. True or false? Do you want to answer now?
So acute pancreatitis.
Excellent. It is acute pancreatitis due to what?
The alcohol.
Alcohol intake and any other supporting thing for acute pancreatitis in this patient specifically?
Diabetes. The metformin. Diabetes.
Diabetes and anything?
Pain radiating to back.
Okay, so answer is right, acute pancreatitis. So what is the most appropriate initial management? Does it need to deal with triglyceride levels in this setting? Are you concerned with triglyceride levels in this setting? Okay. So which lipid pattern is most characteristic of type 5 hyperlipoproteinemia?
नहीं options है ना?
And a follow-up of lipid panel has been done, which shows triglyceride of 420. What is the best long-term pharmacological therapy? What drug you can give to control triglycerides?
So can we go to the previous questions?
Okay.
So the one in which the picture was there.
Answer?
So the one in which picture was the second one. So this the blood one is the creamy supernatant.
Okay. This is just for your idea of the question. This is not a question.
Okay.
Question starts from this.
Okay.
First question, you answered it right. Next to initial management, what are you going to do for this patient? And which lipid pattern is characteristic of type 5 hyperlipoproteinemia?
Type 5. I'm not sure. Triglycerides.
So C.
C. Elevated triglyceride and presence of creamy supernatant after overstanding overnight. Okay. So what is the best long-term pharmacological therapy?
So statins and fibrates.
If you want to go with statin or fibrate, then what you can specifically go for triglycerides?
Fibrates.
Fibrates. Okay. Then are they having high
Yes.
risk of developing True. True, they are having high risk, you are telling. Okay. Then any other initial management? Any idea or how to deal with hypertriglyceridemia? This is actually a case of hypertriglyceridemia induced acute pancreatitis. Okay. It is not actually DKA because ketones are negative and sugar is also at 280 levels. So,
So,
it is not.
so symptomatically only to ID and no,
Okay.
so not sure.
Okay. I've answered three questions right. This is the thing among hyperlipoproteinemias. If you see dyslipidemia, those group of disorders, only this hypertriglyceridemia don't have any risk of developing atherosclerotic coronary artery disease. Only those disorders having elevated LDLs will have the risk of developing atherosclerotic coronary artery disease. Okay, so the answer is false for this. Negative mark for this question, whereas 3 questions you have answered it right. And this one, I can go for the pass. Next team. Any idea? What will you do in a patient of hypertriglyceridemia induced acute pancreatitis? Next team. Who is the next team?
Sir, actually, team 1 has walked out from the quiz, sir. So, team 2 can answer this question.
Okay.
So, team 2, breathing scrubs, you can answer these past questions. And there's no negative marks for this question, so you can answer well. Breathing scrubs, could you please unmute yourself and respond? Am I audible? I guess we can skip to next team, sir.
For the next one.
Oh, I think breathing scrubs are the next. Breathing scrubs.
So the answer
Please,
will
could you
be
please check whether they are in the meeting? So for the team 6, we are giving 50 marks, right, sir? They answer 3 questions right and 1 negative marking. One negative, so 50 marks.
Next team is ready.
Breathing scrubs. I guess they 2 out of that.
Yeah. Okay, then we'll end this session then.
Okay, sir.
Okay. We'll go to that last session.
Last
Sir,
session.
what was the answer to that question? What would be the initial management? Is it lipogenic?
Sir, can we try that question, sir? Answer.
Oh, who wants to try?
Academic
also want to
assessment,
try.
sir.
You can try.
Yeah. We could, sir. Actually, there will be a clash after some team try this question,
Okay.
sir. So
Okay, then
let's skip the question, sir.
Okay. The answer is like insulin can be given for this patient and IV fluids. Insulin actually activates this lipoprotein lipase and it will help in reduction of this hypertriglyceridemia levels. Insulin IV fluids are most appropriate. Okay. Yes. Now let's go to the last round. This rapid
Before
fire.
going to last round, I have to tell the final, tell the marks of the team.
Yeah.
Team 3 has scored 100 marks in this round. Got the total of 225 points. And team 4 got 80 points, and has a score of 180 points. And team 5 has scored 90 points and has a score of 145. And team 6 scored 50 marks, 50 points in this round and has a score of 60 as total.
So let's go to the last round, which is rapid fire. So duration is only 1 minute. Pass is not allowed. Right answer +10. Wrong answer -20. Okay.
So
Can we
for
start?
one question, it's 60 seconds.
No, total for five questions will be there. Total is
Okay,
60.
sir. Okay, sir.
Okay.
So
Who is the first
shall
team
we
now?
start with team 3 again, sir? He has scored first.
Okay. Okay then. Team 3, are you ready?
Sir, yes, we are ready.
Okay. So first thing, pulses alternance characterized by alternating strong and weak pulses is commonly seen in what condition? In cardiogenic shock, cardiac output is low and PCWP, which is pulmonary capillary wedge pressure, is dash.
Sir, one is left ventricular failure, first one.
Okay. In cardiogenic shock, cardiac output is low and pulmonary capillary wedge pressure is dash. Preferred anticoagulant in cancer-associated thrombosis is a 58-year-old man with history of MI, presence for follow-up, LDL is 90 despite being on high-intensity statin therapy. According to ECSC guidelines, next best step in managing his dyslipidemia is what? Fifth question, a 58-year-old woman undergoes ECI with drug-eluting stent for STEMI. Recommended duration of dual antiplatelet therapy for this patient is 12 months. Is it true or false?
Sir, for second, it is high.
High, okay.
15.
Third?
Sir, we would not like to answer the rest of it.
Rest of it, you don't. Okay. Then. So, two things they have answered it right. First is Salvi systolic dysfunction, and next is PCWP high. Preferred anticoagulant is low molecular weight heparin. Okay. And LDL, if it is not controlled by your high intensity statins, you can go to the next therapy, which is ezetimibe. Ezetimibe can be added. And PCI STEMI, after doing stenting, you should be giving double antiplatelets for 12 months. It's true. Next team is?
Sir, how much can I give, sir?
So 20 for this team.
20 for this team. Next team 4. Team 4, dextrocardia.
Team 4 ready?
Team 4, could you please unmute yourself and respond?
Yes, sir.
Yeah.
I'll start the timing, sir.
Yeah. A slow rising pulse with a delayed upstroke is characteristic of?
First is aortic stenosis.
Okay. Cause of absent X descent in JVP. Anticoagulation in pregnancy for DVT.
A
60-year-old patient
reports
muscle aches after starting statin therapy, leading to discontinuation. His LDL still remains at 130. What is an appropriate next step in managing his dyslipidemia? Fifth question, a 65-year-old patient with chest pain and STEMI diagnosis. His Gray score is 145. According to latest guidelines, the recommended timing for coronary angiography in this patient is 72 hours. Post-treatment with anticoagulation in DAPT. Is it true or false?
So we would like to answer question number 3.
Okay.
In the first trimester, anticoagulation given is heparin, and second and third trimester it is warfarin.
Okay.
And
any other question do you want to answer?
Second is constrictive pericarditis.
Constrictive pericarditis. Okay. Any other question you want to answer? Negative will be -20 and the right answer will be +10.
60 seconds over, sir.
Over. Okay. So answer is first is right, aortic stenosis. Next is absent X descent. It is tricuspid regurgitation. In constrictive pericarditis, there will be a prominent X descent. So it's -20. And anticoagulation choice, they told it right. Next is if LDL is raised even after starting, if statin is being intolerant for patients, Next option will be like drugs, like you can try with different statins also, or you can try with other statin drugs like bempedoic acid, ezetimibe, all these things can be tried. And in NSTEMI, latest guidelines, what they are telling is in the NSTEMI gray score, there's a score calculator. If it is more than 140, then you should do coronary angiography within 24 hours. Okay, so it's a false statement. So can we go to the next question? Next team.
How much can I give, sir?
So 0.
For the team 4, 0.
Next team is ready.
Next team 5. Team 5, could you please unmute
Yes, sir,
yourself
yes.
and respond? Academic assessments. Sir, yes, sir, we can change to next question.
A Bisperian's pulse, double systolic pulse is seen in any one condition. A square root sign or dip and plateau sign in ventricular diastolic pressure is seen in what condition? Duration of anticoagulation in provoked venous thromboembolism. A 55-year-old man with familial hypercholesterolemia with LDL of 100 despite maximal statin and ezetimibe therapy. So these patients, what is the next recommended therapy? And a 75-year-old male patient with atrial fibrillation and genstomy undergoes PCI, is already on apixaban. What is the ESC recommended anti-thrombotic strategy? The correct regimen is apixaban with aspirin with clopidogrel for 12 months. Is it true or false?
Sir, first one is aortic regurgitation.
Good. Aortic regurgitation plus 10. Then
Second one is constrictive pericarditis.
excellent. Square root sign, constrictive pericarditis plus 10.
Third one, sir. Third one, 3 months, sir.
3 months, excellent. Duration of anticoagulation in provoked PT is 3 months.
The next one is you can add statin. No,
Statin
one
is-
minute, sir. 1 minute, sir. Sir, PCSK9 inhibitor, sir.
Excellent answer. It is PCSK9 inhibitors. Okay. Fifth one?
Sir,
Is it
fifth
true?
one, false, sir.
False. Excellent. All 5 questions are right. Plus 50.
Sir, actually, they answered after finishing time, sir. The 4th one and the 5th one, sir.
Okay, let's go. Okay, 1 minute timing has been over. Okay.
Yeah.
Sir,
over.
but
Okay.
sir, at least for 4 questions, sir.
Actually, at the end of 3rd question, it's been finished there. I'm just trying to say it's error from our side.
So how much marks, sir?
1, 2,
Sir,
3.
we can give for 1, 2, 3, sir.
Okay. Next team, is it ready?
Can I add 30, sir?
Yeah, 30. Next team, is it ready?
Next team 6.
Yes, sir.
Yes, sir.
Okay.
Heart attack. Yeah.
Dicrotic pulse. Pulse with 2 palpable beats per cardiac cycle is commonly seen in what condition? Kussmaul sign, increased JVP on inspiration is typically seen in what condition? In acute coronary syndrome with atrial fibrillation, triple therapy, which is anticoagulant with DAPT, is recommended for duration how long? And a 40-year-old woman with no cardiovascular risk factor, LDL 160, what is the initial recommended management for this patient? 70-year-old man with history of GI bleeding, NSTEMI, undergoes PCI. Given his high bleeding risk, what is the duration of DAPT? It is 1 month, true or false? Answer soon.
Sir, dicrotic pulse is cardiac tamponade.
Tamponade. Okay, next. Second question.
20 seconds more.
Kussmaul sign in restrictive pericarditis.
Constrictive pericarditis.
Restrictive, no?
Restrictive.
Constrictive or restrictive?
Restrictive.
Restrictive. Okay. Then third.
Triple therapy is recommended for.
But time's up, sir.
Okay. Both are
It's
wrong
crossed
actually.
1 minute.
First, dicrotic pulse will be seen in typhoid fever or sepsis. Small sun characteristically seen in constrictive pericarditis. And this triple therapy is recommended for like 1 month in the ACS with atrial fibrillation. Okay. And any 40-year-old woman, if they have no risk factors, if they come to you with an LDL of 160, the next treatment is to just advise lifestyle modification. There is no need to start any anti-lipidemic drugs for this patient. Okay. And if the patient, these are patients also will be common in your OPDs, like having lot of GA bleeding. Patient might have anstomy, and patient will also be going for ATCA. So since this much high bleeding risk is there, recommended duration of DAPT, double antiplatelet therapy, is just 1 week for such patients. After that, the patient will be shifted to only single antiplatelet therapy. Okay. Yes. So that's it.
Yes, sir. That's the end of our rapid round session.
Okay.
So I would like to tell the total scores for the team 3, team 4, team 5, and team 6. And first of all, I want to appreciate every team for participation and for this involvement for this quiz. So team 3 has scored 245.
Okay.
Team 4 has scored 180, and team 5 has scored 175. Yeah, that's too close. And sorry from our side, that's too close. And team 6, 40. So team 3 has got the first place, and team 4 has got second, and team 5 has got third place.
Okay.
A very big thank you for all the participants for giving your best and making this quiz so lively and exciting.
Yeah, you made actually. I didn't expect this much involvement from you guys. You actually answered so many questions right.
Yes, sir.
Very interesting.
Yeah, sir, for you, heartfelt thanks to you for being a quiz master and guiding us through all these sessions, sir. We've learned a lot today. We really learned a lot today, sir. And once again, congratulations to all the winners and big round of applause from kudos from our side. Yeah, thank you so much.
Okay.
Over to you, Anna.
Thank you, sir. Thank you, sir. Thank you so much. I would like to really thank Karthikeyan sir for accepting in a very short notice and also for giving such a wonderful presentation. Wonderful presentation means it's like complete cardiology can be like a brushed up in the short period of time with this presentation alone. So I have been a student of him in one of the coaching institute, and I have been admired by his teaching. And it's my pleasure to invite you today over this Medmemorate 25 and having you here as a quiz master, sir. And I request you to join at 6 o'clock with us in the valedictory ceremony, where we will be like having our chief guest of honor, and we will be like distributing the prizes for the students, those who have won in the research paper presentation and case presentation, as well as in the quiz. Thank you once again for all for joining with us today. I request Arun to kindly share sir with the link. If sir is free, I request sir to join with us in the valedictory ceremony at 6 o'clock. I request all the students to also join in the valedictory ceremony. It's a event to celebrate the last 3 days efforts of the entire team who have worked day and night in the past 1 week to make this happen within a short period of time with no glitches, no technical errors, nothing. So I'm very proud of the team, and thank you once again for all for joining this wonderful quiz. Thank you, sir.
Thank you. Thank you so much.
Thank you, sir.
Okay.
Thank you so much. Thank you so much, guys, and congratulations once again. Thank you.
Thank you, sir.
Thank you, sir.